On behalf of TASH and our board of directors, I'd like to welcome you to the first TASH Town Hall. This is going to be a monthly webinar that we will be hosting for our members and people that are interested in what are the implications of different public policy issues that have been taking shape with the new Congress and the new administration. This evening, I'm delighted to have two people join us. Allan Bergman, who is the chairperson of TASH's Public Policy Committee, and Nelis, who is our Director of Public Policy and Advocacy. Tonight's topic is everything you thought you might need to know or didn't know about Medicaid. So I'm looking forward to hearing their words of wisdom about how we can do what changes might be under consideration and what we can be doing about those changes as advocates and people who might be affected by them. So I'm going to turn it over to you, Allan.
Thank you, Ruthie. Good evening, everyone. It's a pleasure to be here, and welcome to the first of many of the town hall meetings. I'll be using PowerPoint slides this evening to go through this with you. And what I intend to do is give you an overview of what Medicaid is, how it may be working in your state, and what is potentially at risk with the various versions of the American Health Care Act, or what you have often heard as repeal and replace the ACA or the Affordable Care Act. I will put a footnote on this by saying the issues have been changing almost daily. I'll say that this should be current as of this morning, but I won't guarantee it's current as of this evening or tomorrow morning, given the continuing activity of members of Congress and the White House. So with that, we will get started. And I'm going to start with the purpose and some of the key language in the Developmental Disabilities Assistance and Bill of Rights Act, since I believe it applies to just about everyone who has interest in TASH and is a member of TASH or benefits from TASH's advocacy. This is the paradigm that has shifted dramatically in the last 40 to 50 years from a deficit model, a fix-it model, a medical model, to one that promotes self-determination, independence, productivity and integration, and inclusion of all facets of community life, built on a person-centered plan that identifies strengths, resources, priorities, concerns, abilities, and capabilities. I set that at the tone here as we get into what Medicaid does, what it may be doing in your life or the life of a family member or a friend or somebody you work with, and what potentially could be at risk should there be major changes in the structure of Medicaid in this country. Going back to the very beginning, Medicaid was created in 1965. It's technically known as Title 19 of the Social Security Act. Medical assistance, in some states it is still called that. As I will mention, and as Tia I think will mention later, Medicaid isn't always called Medicaid in your state, and part of what we want to do is make sure you know what Medicaid is paying for, even if it's not called that in your state, because it's at risk. So the first purpose of Medicaid is often what most people think about as a Medicaid card, medical assistance for families with dependent children. That now is TANF, temporary aid to needy families, low-income women, children, and then aged, blind, or disabled. This is now generally referred to as the SSI population, supplemental security income, old age assistance, aid to the needy blind, and aid to the permanently totally disabled when this law was passed in 1965. And it's means tested. It's a poverty program from its original beginning. Again, historically, because it keeps coming up, Medicaid and Medicare, which is Title 18 of the Social Security Act, were both passed in 1965 as part of Lyndon Johnson's Great Society. And he, a formidable president, former Speaker of the House, was unable to get what he wanted to do then, as predecessors tried and successors have tried, which is single payer or universal coverage. This was the best he could do, was 2 different federal programs, Medicaid being a federal state program, Medicare being totally a federal program. We're going to concentrate tonight on Medicaid. There is a second purpose in Medicaid, which is often not talked about, and it's been there again 52 years. This is critical to the work that we are doing with home and community-based services waivers, personal care, community first choice, and many of the other things that have evolved in Medicaid. The second purpose in law, rehabilitation and other services to help such families and individuals. That would be individuals with disabilities, individuals who are aging, individuals who are blind, attain or retain capability for independence or self-care. Very consistent with the goals of the Developmental Disabilities Assistance and Bill of Rights Act, and certainly very consistent with the goals of the Individuals with Disabilities Education Act, the Rehabilitation Act, Workforce Investment Opportunity Act, and even the newest Medicaid rules. So why is it that those of us who work in Medicaid say, you've seen one Medicaid plan, you've seen one Medicaid plan? There are 50 variations on the theme. I meet with folks in different states. I've met with people who move, and they say, but in my state we could get this, and in this state I can't. Medicaid is a menu. There are certain things that a state must do. We call them mandatory. Mandatory eligibility, mandatory services. Mandatory eligibility is what I just went over with you. People on SSI and people getting temporary assistance to needy families. Everything else is optional. Expanding Medicaid to poverty or above poverty, expanding Medicaid for workers with disabilities who can then earn up to a vast amount of money. Some of you may know Section 1619A, 1619B. There are unbelievably number of options that states can pick and choose, add to, and delete. The same is also true on the service menu. There's a core service menu, I'm going to go over that with you in a minute, of the mandatory services. Everything else is optional. So if a state wants to do basic Medicaid, it can be a pretty slim program. It can then add and delete the options at its will on 30 days notice. The key piece on any of the services, though, is what's called amount, duration, and scope. How much, how often, for how long, to what end. And as long as it meets the fundamental purpose, as I showed you earlier, medical assistance or rehabilitation to assure independence or self-care, then the state can control how much of physical therapy somebody can get, how many doctor visits they can get. That's all in the contract that gets negotiated with each of the states, and the states present this to the federal government. The operating agency we call CMS today. It's the Center for Medicare and Medicaid Services. It is part of the Department of Health and Human Services, a very large federal agency. The other things that states can do, they can look at whether they're going to do it statewide or do it in designated counties or geographic areas. Are they going to do comparability, that is, offer the same benefit to all the different populations? Or they can say, for this population, we'll do X, for another population, we'll do Y, for another population, we'll do Z. And then there is freedom of choice of providers unless the state chooses to go to a managed care system. And then even when they go to managed care, they usually require at least 2 managed care companies to choose from. Last, and probably most important, the states control reimbursement, how they pay, fee for service by the quarter hour, by the hour, by the day, by visit, by benchmarks, by milestones, by performance, and how much they pay is all left to the state. The good news is in the last 5 years, the federal government has applied a much higher standard at looking at rate and reimbursement methodology because of lots of complaints from, in our field, community providers, but also physicians and hospitals that they're not even covering their costs, let alone getting anything close to what they might be getting paid by Blue Cross Blue Shield, Aetna, Humana, United Healthcare, or any of the health insurers on the healthcare side. Also, there are minimum standards from the federal government about provider standards, and then states may raise those. All of that goes into the Medicaid state plan that the state submits and reviews and negotiates with the federal government. Most important, in addition to all of those variables, is how states get money. There are matching funds and there is no cap. So if the state of New York tomorrow, or the state of Maryland, or the state of Virginia in the legislature said, we want to add a new service and we'll put up $2 million, and they're a 50-50 state for matching, I'll come back to that in a few minutes, then in fact the federal government is obligated when the claims are submitted to pay the matching money. So 2 million becomes 4 million. And there is no cap, there is no line item in the federal budget. Just as Medicaid is an entitlement to a person, the Medicaid federal dollar is an entitlement to the state. That's what's at risk with the changes that we're going to be talking about. So here is the list, and you're going to be able to get the slides. They'll be up on the TASH website probably early next week. These are the things that a state must do if it does Medicaid. Inpatient hospital, not inpatient psychiatric for people with mental diseases. Outpatient hospital, rural health, lab, x-ray. One of the ones that's been a problem for us is nursing facility services for folks over 21. So nursing homes have been a mandatory Medicaid service since 1965. We often refer to this as the institutional bias because all of the home and community-based services, and we'll talk about those in a minute, are optional to the states. They are not mandatory. Family planning services, mandatory. Early periodic screening, diagnosis, and treatment, I'll come back to that in a minute. Physician services, medical surgical services of a dentist. This is not dental care. This is if you need oral surgery, to have a tooth taken out, they'll pay for that, but Medicaid does not have to pay for preventive care, cleaning, routine fillings, all of that kind of stuff, caps and bridges, unless they choose to, and that's on the optional list. Home health, nurse midwife, nurse practitioner, if it's a licensed service, pregnancy-related services. So those are the mandatory services. If a state does Medicaid, they have to have those, but again, they can determine who gets it and how much of it you get and how much the provider gets paid. So lots of controls of the state, in spite of our hearing from the administration and Congress that states need more flexibility. Most of us believe states have phenomenal flexibility. That's why we have 50 very different Medicaid plans. This early periodic screening, diagnosis, and treatment is a superb benefit for any child who is under the age of 21. It has been tested in court. Plaintiffs have won consistently. So even if a state does not have the service in the optional category, prescription drugs, for example, if it's medically necessary to treat or ameliorate a defect, physical and mental illness or condition identified by a screen, it must be provided, whether the state normally does this or not. This is a superb benefit for children who have a Medicaid card. It is what I've often referred to as platinum. It's as good, if not better, than any commercial health insurance. It may be at risk as well. Now, the optional services, there are many more. What I've highlighted in red are those that have more application to individuals with disabilities and chronic health conditions, not that they all don't. Medical or other remedial care. That could be a chiropractor, that could be certain kinds of therapists, that could be a variety of licensed folks in a state in, quote, the healing arts, but they're not physicians. Private duty nursing, a critical service for many folks with chronic health conditions, ventilator dependent, etc. Clinics, outpatient clinics. Therapies are optional. This always seems to amaze people that PT, OT, speech language pathology services are not mandatory, they're optional for a state. Prescription drugs are optional, as are eyeglasses, dentures, and prosthetics. But again, remember, for children up till their 21st birthday, if medically necessary, all of these apply. Rehabilitative services, optional. ICFMR, the Intermediate Care Facility for individuals with, IDDD, but old language MR, the private or public institutions are an option. Nursing facilities other than those in an IMD and for folks under 21. Inpatient psychiatric services for children and adolescents. Personal care is an option. Attendant care is an option. So, and transportation. So again, the take-home point here is you really need to know what's in your state plan, because it's different in every state, particularly on what's in the optional menu. Emergency hospital, home and community-based services, waivers, or the newer state plan for home and community-based services. Some states have as many as 8 or 9 HCBS waivers targeted for different populations. Some have 2 or 3. We added in the Affordable Care Act, and I'll talk about it again a little bit later, community first choice. 8 states have chosen that to create an entitlement to personal attendant services. Medical health homes are optional to coordinate care for people with chronic health conditions or multiple issues, and for people with persistent mental illness and a secondary health condition because of the large dual diagnosis in that population. So the money, let's look at the money for this deal. It's a lot of money, mega billions of dollars. And as I mentioned earlier, it's an entitlement to the state with no cap. It's calculated every year for what's called FMAP, the Federal Medical Assistance Percentage, the matching funds ratio, for every state. No state gets less than $50. That's the big states, New York, California, Connecticut. It's all based on per capita income, population, and other factors. The highest rate this year is Mississippi at 74.63%. So to make that simple, if Mississippi sends in a bill to the federal government for $100 worth of Medicaid, they're going to get a check back for $74.63. If New York sends in a bill for $100 of Medicaid, they're going to get a check back for $50. So the matching ratio varies. This was done to make it easier for the poorer states to have a good Medicaid program. It has not turned out particularly well that way. The poorer states in general tend to have weaker programs than the wealthier states. If we go to either a block grant or a per capita cap, this open-ended matching as we have known it will become history and will be very detrimental to people with disabilities, to providers, and to states. So here's what Medicaid looks like today. It's the largest health insurer in the United States. 73 million Americans in any given time period this year will have a Medicaid card. But the important piece to know is that 21% of the population getting Medicaid, about 15 million people, are folks with disabilities and seniors. But pay really good attention here, 48% of the money is spent on 21%. The women on welfare and their children are relatively inexpensive. Medicaid pays for half of all births. It pays for a large portion of nursing home. Again, a terrible mistake out there by many seniors believing Medicare will pay for nursing home. It only pays for rehab post-surgically. It does not pay for long-term nursing home care. Medicaid is the largest source of federal money to the states, and in most states, it is the largest single expenditure in the federal budget, averaging about 22% when you add the state and federal share, and in some states now as much as 27 to 28% of the federal budget. So Medicaid is in the target for both the federal folks and the state folks. But again, important for us to know that people with disabilities and seniors, because we access health care and long-term services and supports, disproportionately spend the Medicaid money. So put on your green eye shade hat. If you're now going to be set with a cap in your state, you're probably going to disproportionately hit the high users, or what are perceived as the high users, which are people with disabilities and people who are seniors. So where'd this all come from? And again, I want to quickly walk you through how we got here, because originally Medicaid was just skilled nursing care in 1965. There it is. It was an entitlement. It's the institutional bias. Then we added intermediate care facilities, not skilled nursing, in 67. And we got into it in the DD business in 1971 as a way to prevent state institutions converting to nursing homes, which they were doing because they were chasing the money. In 1981, we began the journey for home and community-based services with what's called the Medicaid option waiver. So this is the waiver to waive the institutional rules that are in nursing homes or ICFs or actually hospitals long-term, and for a state to create a menu of what we call HCBS, home and community-based services. That started in 1981 and has grown considerably until about 3 years ago. We now spend more nationally in home and community-based services than we do in institutions. In the DD world, that happened about 7 or 8 years ago. But nationally, for all populations, we are now spending more than 50% of long-term services and supports in home and community rather than ICFMR skilled nursing facilities. In 1982, we broke a barrier by creating an option for state to waive the deeming of parental income for children under the age of 18 who would otherwise be eligible for long-term institutional care, because we had an anti-family bias that said if you have a kid living at home who meets all those criteria, then we have to look at the wealth of the family, because remember, Medicaid is a poverty program. That got changed through the advocacy of Julie Beckett on behalf of her daughter, Katie. Katie unfortunately passed away a couple of years ago, but she was the first ventilator-dependent child to go home with Medicaid without bankrupting the family or telling them they had to spend down into poverty. They could still maintain a modest middle family income life. In 1986, we added supported employment and respite care to the home and community-based services waiver packages. States could choose to do that. We did some nursing home reform in 1987, including an annual screening to make sure that people who were there were given the choice to come out. Not well done, but it's there. And then a big watershed in 1990, when 8 states applied for and received funding to do something called community-supported living, which was our first attempt to separate housing from supports. Today, we would call that supported living. Prior to 1990, that was illegal in a waiver. A waiver had to be a licensed group home, or you had to be in the family home. But then we did this, and at the end of 5 years, you'll see at the bottom of the slide, all the experiments were very successful, and supported living became something that any state could do starting in 1995. Unfortunately, we still have many states, including my home state of Illinois, that does not offer supported living in its home and community-based services waiver. We added a frail elderly option in 1990. Personal care became a major expanded service in 1992 as an option. These are all options. And I wanted to take us back to the New Freedom Initiative of President Bush, who gave us the Americans with Disabilities Act in 1990, and read to you something he said as part of that directive to say where we've come from, but where we still need to go. That what he's saying is, in order to place qualified individuals with disabilities in community settings whenever appropriate, and we all know it's always appropriate with the right supports, it's hereby ordered as follows. Federal government must assist states and localities to implement swiftly, I guess we have to define that term, this was 01, the Olmstead decision to help ensure all Americans have opportunities to live close to their families and friends, live more independently, engage in productive employment, and to participate in community life. Sounds like awfully good stuff to me. That's coming up on 16 years old, and we are looking at a potential now where that would be buried and in many cases become impossible to do. In the Affordable Care Act, which was passed in 2010, we did some enhancements of services under Medicaid. Not that there was the expansion and some of this. The bulk of the Affordable Care Act was also on creating exchanges in the individual purchase market. We're not going to talk about that today, even though it has great implications for people with disabilities and their families. We added something called Community First Choice. I'm going to show you what that is. 8 states now have it. We added a state plan option, not a waiver, for home and community-based services for people who don't have to meet institutional care, including people with psychiatric disabilities. We added aging and disability resource centers. They're in all your states now. They could be repealed. We had Money Follows the Person to move people out of institutions, and state rebalancing grants. I believe 73,000 people have left institutions because of Money Follows the Person enhanced Medicaid in almost every state. So here's this Community First Choice. Thanks to our colleagues at ADAPT who have been trying to undo the institutional bias since the early 90s with what then was called Mi Casa, or My Home. We have moved greatly forward, and it's really a pretty broad statute of definition. This does require institutional level of care, and it's an entitlement. If your state chooses this, and I'll show you the 8 that have, there is no wait list like there can be for home and community-based services. If you're eligible, you get it, and it's a functional eligibility, not diagnostic. It's tied to activities of daily living, instrumental activities of daily living, health-related tasks, hands-on assistance, supervision, and queuing. The key piece to this was the sweetener to states to do this, was they get an extra 6%. So if the state match is 50, they get 56. That's a lot of money in a big state, even in a small state. That, you will hear in a few minutes, is in jeopardy for the states that have done it. This was to try to create a financial business incentive for states to say, we want people to live at home and in the community, and we're going to give you an extra matching dollar to do it. First of all, it's cheaper, but we're going to give you more money on the federal side to do that as well. This is proposed for repeal in 2020. Functional need, you can have eligibility to 300% of SSI, home or community setting. You cannot do room or board, and limited assistive technology. You can do medical supplies. But nonetheless, a big advance. Here are the 8 states that have chosen to do this. I hope we have people on from some of these states because they are making major inroads, including using some of these dollars to redirect money from home and community-based services waiver because of the extra 6% match. Also helps with waiting lists in these states. People may not get the full waiver, but they're going to get some personal support services. These dollars, unfortunately, cannot be used for supported employment, customized employment, or job coaching. Medicaid state plan for home community-based services also added, and lots of advice on this. All can be different. State-wideness can be waived. So again, it's very much like the typical home and community-based waiver, except it's not a waiver because these are people who are not eligible for institutional services under the Medicaid law. So lots of folks with psychiatric disabilities. This could also be people with mild to moderate developmental disabilities who don't meet the state's long-term care criteria. Lots of folks with traumatic brain injury, acquired brain injury, elders with early Alzheimer's or dementia. So there's a lot of folks, and many states have aggressively pursued this, most active being in mental health services, services for people with autism, and some with early aging. Okay, here are all the things you can do. And again, you'll look at this and say, but my state doesn't do that. They don't have to. This is a choice menu, but these are all the things that states can do under home and community-based services when they do their waiver or their state plan amendment. It's quite a menu, and other can be anything that the state wants. Peer mentoring has been approved in several of the mental health services. Individual self-advocacy, peer advocacy has been approved in at least 2 states in DD. Again, not level of care for institution. And so what's going on? Now let's bring us up to date. And I hope that's been helpful to give you sort of a 50-year history of the evolution of Medicaid to become the largest insurer and the largest provider of long-term services and supports in this country, by far, in partnerships with state matching dollars. The current agenda in Washington is to repeal and replace the Affordable Care Act, more commonly known as Obamacare. The goal is to reduce the cost over the next 10 years of Medicaid to the federal government and to change the role of the federal government in healthcare and paying for healthcare for people that are not themselves. The Congressional Budget Office, on the most recent revision of the American Health Care Act, as it is called, says we will reduce federal expenditures for Medicaid by $880 billion over 10 years. I have no comprehension how much money that really is, except it's near $1 trillion. And most of it is going to be used for tax cuts for the wealthies and for wealthy people and corporations. And as you will see in a few minutes, the expectation is that states will be able to save this, but if they can't, then the states and counties will have to come up with the difference. We have this Medicaid expansion. You can see there are 31 states, your state is probably in there, who have expanded to 138% of poverty to get insurance to people who had none. There are a lot of people who get this now. Again, it is scheduled to go to 90% state share, federal share, 10% state share in 2020. That's all proposed to change dramatically in the American Health Care Act. And there are a lot of people with disabilities. We count from a couple of the surveys, 20 to 25% of the people who are getting Medicaid expansion are people with a range of disabilities, including mental health conditions and chronic health conditions, and some of which are allowing them to go back to work. Okay, here we go again. Medicaid was 4 million people and $900 million in 1965. Poverty rate has a piece in here. Aging does, the demographics of aging. If you're not tracking it, baby boomers are hitting 65 at 10,000 per day and will for about 7 more years. As soon as they hit 65, they get a Medicare card. And if they're not wealthy, they may end up also on Medicaid, particularly if they need long-term services and support. So the demographics are working at growing Medicaid, and the lifespan of individuals with disabilities is also growing and approaching typical lifespan, so that somebody with a disability is going to live to be 80, 85, or 90, just like their peers without disabilities. So we're talking about changing this formula of matching money, and the 2 strategies on the table are either block grants or per capita caps. Fancy words thrown around. They're just nice ways to say, we're going to cap the amount, we're going to limit the amount of federal money that states are going to be able to get. Okay? And regardless of increased need, like Katrina, when a lot of people had to go on Medicaid, economic shift, demographic changes, the Zika virus, any of that, Medicaid has always rallied, and the feds have picked up their 50 to 75 cents on the dollar. That will not happen if we go to either of these flexible capped plans. So again, if you're a Medicaid director, you've only got a couple of choices. You can cut services or hours of service. You can reduce payment rates. You can narrow who's even eligible to get Medicaid or any of the Medicaid services, or any combination. And as I mentioned earlier, people with disabilities and seniors, because we are disproportionate users, will probably be the target. There's not a lot they can cut from children and low-income women. Most of those kids are relatively healthy. Some have asthma. A few have juvenile diabetes. Most of the moms are relatively healthy. So that we're going to be in the center of the bullseye. If we go with a per capita cap, it now appears there will be 4 of them. Again, we don't know for sure. That's why I list all the different options here. But what it appears now is there'll be 1 for children, there will be 1 for women, there will be 1 for people with disabilities, 1 for seniors, and there may be 1 separate one for the Medicaid expansion population. We don't think they're going to break it down more than that. And once they set that on your state, and the variation right now across the country is huge, that's it. That's what you're going to get. There may be medical inflation growth, but if the per capita cap for somebody with disability in a state is, say, 30,000, and in the neighboring state, because they've been spending more, is 45,000, the state at 30,000 will never get a chance to catch up. It will be fixed at 30,000 plus inflation. The states that are really going to get punished in this, and I've tried to bring this to people's attention, are the 15 states in this country that have nobody living in an institution. They are capped at what they're spending in their home community-based services waiver, their community first choice, some of their healthcare stuff, but they're not going to be able to leverage any more federal money as they've been trying to do with renegotiating waivers, rate changes, wage increases for direct support professionals. That'll all have to come out of state funding, because there's not going to be any more federal dollars beyond what this would put in place. So a block grant would cap the total amount of money coming into the state and say it'll only grow by so much a year. Per capita cap would cap it by population, and if more people were enrolled, they would get that per capita cap. So the example I gave of 30,000, if the state enrolled 5,000 more people next year with disabilities at 30,000 apiece, and the state could come up with the 15,000, the feds would come up with the 15,000. It doesn't mean it goes to the person. It can be spent differently, but that's all you're going to get. And as population needs change, as people with disabilities age, and their needs perhaps become more complex, there would be no way to grow the per capita cap. That means crunching services, rates, eligibility, or dollars again, or provider rates. Any way you do this, the state is caught holding the bag, and unless your state is wealthier than any I know of, because 33 states are facing state budget deficits on the general fund next year, states don't have the funds to pick up the slack. Okay? So again, and when they're going to use 2016 as the base year, so you can't even try to get it up this year or next year. 2016 has already gone to the bank. We know what that is. And from there, anything that was projected to grow will only grow a very limited amount. And states or counties will have to come up with the replacement revenue or make major cuts. It's really pretty ugly and pretty painful to think about. And the cuts would grow each year because the costs will grow up faster than what they're going to allow. Say they allow 3% or 3.5%. And we're in trouble. We're in big trouble. So this then becomes, what do we do about it? And my goal here was not to depress you. It was to get you angry and motivated and ready to go to war, because literally life is in jeopardy. Individuals with disabilities of every age need to be mobilized, need to understand that everybody is impacted, and to understand what Medicaid pays for in your life that you may not realize. In a number of school districts in this country, low-income kids have their OT, PT, speech, and other related services paid for by Medicaid, because Medicaid pays for related services if the school or one of its vendors chooses to be a Medicaid provider. There are a number of states that have done this, and those dollars could be cut. Schools could reduce that, and those dollars offset the general fund dollars and the local district dollars to be sure that hopefully in most districts there is enough OT, PT, speech, language, psychology, nursing, paras, etc. That could all be scrunched. So it's not only adults. It could be family support. It could be respite care. All of that early periodic screening, diagnosis, and treatment. If there's a children's waiver, a Katie Beckett waiver, that could be cut, it could be narrowed. The standard for family financing could be changed, could be eliminated. Those are all options, all right? So people need to work at spreading this word and helping everyone who's getting Medicaid understand they're in jeopardy. This isn't just for a targeted group, and a lot of people don't know their money is Medicaid. And then to be able to paint the story about what Medicaid does for you today and what could happen to your life if you lose it or curtail it. So that's really the important story. Starting on the high note, I have life today, I live in the community, I have a job, I have meaningful day, I go to school, my family has respite, the families can talk about this, they're able to keep a job. There are a lot of stories, and if this were to be taken away, what are the negative impacts on individuals, on families, on communities? I wanted to share with you a list of 23 targeted members of the House of Representatives who won their election or re-election last November as Republicans, but Hillary Clinton won their district on the presidential race. So these are folks who are not in an ultra-conservative district. Their district would be more moderate to liberal. They didn't vote for Donald Trump, but they voted for these Republicans. They're highly vulnerable, we believe, come November of next year when they're up for re-election. So California has 7 of them. These folks need to get lots of messaging. Everybody does, but these folks in particular, they could be the swing votes in deciding how this will play out. We have 2 folks in Florida, 1 in Virginia, 1 in Minnesota, 1 in Colorado, 1 in Illinois, where I live, 1 in Arizona, 1 in New York, 2 in Texas. Pete Sessions, by the way, is the dad of an adolescent with Down syndrome who was a major sponsor, co-sponsor with Senator Harkin of the Workforce Investment Opportunity Act and triggering youth 14 to 24 as the priority for supported employment, customized employment, integrated employment. So he should be on our side, but he's got to be reminded of that. Washington has 1. We have 2 in Pennsylvania, 1 in Kansas, and 1 in New Jersey. Those 23 members of the House need to hear from their constituents. It's great if they hear from the state chapter of TASH or other organizations, but at the end of the day, ladies and gentlemen, we're talking about votes. People who vote, people who are constituents, people who can make a difference now by the implication that I need you to do this or I may not vote for you come November of 2018. You don't say that in the letter. They're your eyes and ears. They're supposed to represent your voice, but if they don't know what's on your mind, they can't do that. So these folks, as well as all other 412 House members and 100 senators, need to hear from us consistently with the message, do not repeal and replace Medicaid, leave Medicaid as it is, no per capita cap, no block grant. We don't want it. You will hurt people's lives, and then tell the story. And I found this a while ago from Mr. Lincoln. Last time I checked, he was a Republican. The people know their rights, and they're never slow to assert and maintain them when they are invaded. Our rights are being invaded and potentially terribly destroyed with what is on the table for potential discussion when Congress comes back in 10 days from their current spring recess. They're home until April 22nd. Check and see if town hall meetings are going on in your community now and next week. Show up, ask the tough question. Make sure that your friends and neighbors know what's going on. Share the news, share the information. This is not just a disability issue. This is a community issue. This is a family issue. This is a congregational issue. This is an employment issue. Everybody has a stake in this when they hear what's going on. And I think the epitome of when we've achieved real inclusion is when we have colleagues from outside the disability community, friends, neighbors, coworkers, employers, showing up at the town hall meetings, writing the letters, sending the emails saying, how dare you mess with Susie's life or John's life or the Jones family life. Their life is good because of Medicaid. This is happening because of it. Without it, it would be a shambles. I pay taxes too. I want my tax money to support these kinds of issues. And they're hearing the heat, and we need to just keep it up. And everybody can do something, and it's not somebody else's job to do. That concludes my overview and some detail, Ruthie. I hope that's been helpful. And I will turn it back to you now to introduce Tia.
Great. Thank you very much, Allan. I think people really appreciate the history. And I always look at where did this come from so that, and why was it started in the first place? In the first place, it was to really make sure people had healthy lives and had the supports and services they need. So now I'm going to turn it over to Tia, and she's going to break down some of the things that Allan explained and talk a lot about what we can do as advocates and people with disabilities and family members, and how we can mobilize as TASH members to get our message across that Medicaid is very, very important to people's lives on the day-to-day basis. And so I appreciate that. And when Tia's finished, then we'll open up the floor for questions and answers. So take it away, Tia.
Okay, hello everyone. Thank you for signing on tonight and to hear our webinar, because it's very important. I want to start out for what is Medicaid? Medicaid services serves children, low-income adults, people with disabilities, and the elderly. Medicaid provides medical services, mental health services, and home and community supports for individuals. Without Medicaid, many people would not be able to live and attend school or work or recreate in their community. Medicaid is not always called Medicaid. In your state, it may be called something different. For example, in Maine, Medicaid is called Maine Care. In Georgia, Medicaid is called Compass. And in California, Medicaid is called Medi-Cal. Please refer to our toolkit that you will find out what Medicaid is in your state, what Congress has been up to. Recently, Congress attempted to cut Medicaid in order to reduce its growth and reduce taxes for the wealthy. Medicaid is safe for now, but Congress and the Trump administration will not stop attacking Medicaid. Congress has one-sided view of what Medicaid really is. Remember to tell your story so representatives know what you want and what you need. Please refer to our toolkit to find out how to contact your members of Congress and your government to support Medicaid. On the TASH website, there will be a link that tells you how to contact your representatives in your state and to tell your story. It's very important that we all do this as people with disabilities, to share your story and make sure that everybody out there knows how you feel about Medicaid and to stop them from cutting things. Thank you.
Thank you, Tia. I appreciate everyone coming and listening to the presentation this evening. At this point, I will open the floor up for questions and answers, and we'll get Tia and Allan to field questions. So we have one question. How do people find out who their representatives are? Tia?
You could find out who your representatives are. There's the last time on Facebook and other places, they have a 1-800 number that you type in your zip code and it tells you who your representative is. It makes it really easy for people. Just type in your zip code on the phone and then they tell you, they connect you right to your representative's office.
Ryan said hello. Ryan Dunkerwood to all panelists says hi.
Hi, Ryan.
Okay, one comment on contacting your representatives or any elected officials in Washington, never by snail mail because of the anthrax scare we had a number of years ago. It either should be by phone or by email. Phone is best. Very often we're jamming their lines. That's okay, that's a good thing. And important to know, the staff on Capitol Hill or in their district offices, which are the ones closer to you, do take notes and keep score. They literally keep a score sheet. How many calls do they get or emails on a particular issue, pro or con? So I can't convey to you enough that your voice counts, your vote counts. I was recently with some congressional staffers in Minnesota for Partners in Policy Making, and they confirmed for the group that at a minimum they translate one voter's call to at least 10 other similarly situated voters. If we get 50 people calling, that's like 500. They're paying attention. You get 100, that's 1,000. They're paying attention. So please share this with your friends, your colleagues, your neighbors. Your vote counts, but it's multiplied times 10.
Are there any other questions that people have? This is Drea. When talking with my congressman, he typically says he understands the concerns, but that Medicaid spending has got out of hand and cuts need to be made somehow. I'm not sure how best to reply to that.
Let me take a shot. Number one, I think when he says it's out of control, compared to what? If he looks at the per capita cost of people on Medicaid, particularly the women and children, and compared that with any commercial health insurer, the costs are lower. The costs are lower per person than on Medicare. So he has to remember the number of people who are on it. And he also has to understand, and you have to remind him, that for people with disabilities and people who are elderly, it's both Medicaid health care and long-term services and supports, and that as the population gets older, there are going to be more people who have greater need. So I think the critical issue here is to help the congressman and ask him then, what do you propose is going to happen to me? And there was a video done by the Disability Rights Education and Defense Fund about 2 weeks ago, a woman with spinal muscular atrophy. I'm sorry I didn't have a chance to load it up here, telling her story and saying publicly she believes that she's feeling now that people want her dead, because she said, I'm expensive whether I'm at home or if I can't be at home. She's got a ventilator, she's got tubes, she's got a life, she's working, she goes on vacations, that she would have to be in an acute care hospital, not in a nursing home. And she said, I'm getting the feeling that people want me dead. And I think part of what we have to go back to here is, what is the purpose of the Medicaid program and what's the alternative? And I think particularly in our world, to show them the cost difference and quality of life difference between home and community-based services and supports, as well as an institutional cost. You can tell them the average cost of a nursing home in this country today is $93,000 per year. Why aren't we doing a better job with Medicaid to help seniors age in place? That's what most of them want to do. But they're lobbied heavily by the nursing home industry. So I think we have to be sure we put real pictures and real faces to counter that kind of stuff. Because if they just come back with it's all about the money, yeah, I gave you statistics, but what I said to you at the end and what Tia said, you've got to tell your story, how your life is today and how your life could be devastated if Medicaid was significantly cut. For some people with disabilities who use personal care services or support, they could lose their job. Is that what they really want? Then people have a more dependent life and they give up paying taxes and having meaning in their everyday life. Kids going to school, if they don't get the full benefit of the education, they're going to be totally dependent the rest of their life. And I guess it depends how cynical you want to be and say, fine, then do you want to just kill us all and let's make it simple? Then there'll be no cost. That's something you have to decide. But I think we can't sit by and let them say it's out of control. It's only out of control because the population demographics have shifted and we don't have good health care for a lot of people who then have to come on Medicaid for a variety of reasons. And so personal stories, faces, and I think, again, support from members of the non-disability community with us saying, this is important to me as a taxpayer as well. I hope that helps a little bit.
Another question, Allan, is how can we help people understand how serious the threat is to them?
I did my best to do that. I think given the amount of money that is spent in Medicaid, almost half of it, on people with disabilities and seniors, when they only make up about 20% of the population, if I'm sitting as a Medicaid state director, if either the block grant or per capita cap comes down, I'm going to be sitting there and I have only 4 things that I can do. I can tighten eligibility, which means I might throw some people out. I can reduce the service menu, get rid of certain services. I can reduce the amount of services you're allowed to get in a week or a month, or I can cut the provider rates. Any one of those is going to hurt anybody who's on this call. Nobody is immune. Nobody is subject to being in a special category that, well, it won't happen to me, it's only going to happen to somebody with quadriplegia, or it's only going to happen to somebody with a ventilator. It will not be that targeted. It will be targeted to either key eligibility standards, income, or disability. Waivers could be tightened. They could say, okay, to get a waiver for people with developmental disabilities, you have to have 4 out of 7 functional limitations, not 3. There's nothing illegal about that. So you could be getting a waiver service now or a waiver package with an individual support plan, and you could lose all of it. Or they could say, we're not going to provide more than X hours a week or a month of personal care or direct support staff or hours of day services. So they could say, you don't have to do a 5-hour day, 5 days a week, which we know isn't great, but it's better than sitting home. And instead, you just get to sit and rot at the group home or in the ICF all day. All of those will be legal because they're going to be cutting back on regulations as well. And then we could win maybe, but we'll have to go to court for 5 years. So I think everybody needs to appreciate their Medicaid card, their Medicaid services, Medi-Cal, or in Tennessee, it's TennCare. People in Illinois refer to it as the SILA waiver or the DD system. People have got to go to the TASH website and look and see what Medicaid means in your state. There is no one in the disability community, in my opinion, who will be immune from some punishment if either a block grant or a per capita cap were to be enacted in Congress, because it's already going to be based on 2016 costs. So there's not even a chance for a state to say, give us 1 more year to ratchet up and put a lot more money in the pot. I hope that's clearer.
Well, Allan and Tia covered a lot of information tonight, and it had a lot of detail about what Medicaid is, its history, and how it works now, and also how it might work if Congress and the administration make the changes that they proposed that were fortunately didn't pass a couple weeks ago. So just to help everyone take this information and really use it back home where you have a chance to talk to your congressman, your representative, your senator, and also your state officials, to let your governor know and your state representatives know that this is not something that they should get, that their state should support. Next Tuesday at 6, T and I are going to do a teach-in. And what that means is that we're going to be going over the TASH toolkit. And the TASH toolkit has information in it about how to contact your representatives, how to tell your story, what are the important things to include in your story, how to get your message across. Also, it also has information about how to write a letter to the newspaper to tell people what you think and how you want people at the newspaper to know whether or not this is going to affect them and how it's going to affect them. So you can tune in. We're going to have information on TASH's website, also on our Facebook page and on Twitter. And you can find out the information about how to hook up with the teach-in next week. And it will give you lots of great ideas and lots of great hints about how to take this information and use it to fight to keep Medicaid safe and continuing to provide the services and supports that everybody needs in the future.
Ruthie, can I make one more point?
I was going to say, if you have if Tia or Allan had anything closing to say.
Yeah, well, I just realized, I think the most important piece to remember, this is far from over. We had a short-term victory a couple of weeks ago. Then you probably read that President Trump said, I'm dropping this, we're going to work on tax reform. As of this morning, that is no longer the agenda. Medicaid and the repeal of the Affordable Care Act is front and center, in part because of all the tax cuts that are in it that they want to use as a springboard for further tax reform. So don't be deluded by the games that are going on. This is a critical issue. It was a campaign promise that was made by many members of the Congress and by President Trump. And we are in the target of that. We are the bullseye of the target, and we must be relentless on our advocacy as they are on their being relentless to get this thing dismantled, because everybody's in jeopardy. And I don't even want to begin to think about how ugly it could be within 12 to 18 months. So please don't get suckered by the misleading media, or even that, oh, we're going to let this lay low. They're working on it literally right now, congressional staff, while their bosses are on recess. So please, this is in my opinion, the highest priority. We have many other issues with Congress, but if we lose this one, the others sort of become not that big a deal.
And I would like to say that people with disabilities, there's a lot of us out there, and if we make our voices heard, it could make a big, huge difference on the impact of how this goes. Yep. So we need to make sure that everybody that you know and your self-advocacy groups out there in the disability world makes their voices heard loud and clear. It's time to speak up and speak out.
Thank you, everyone. So be on the lookout for the information about the teach-in, and we'll see you next week. Y'all have a great weekend, and I appreciate all of the tech support from Donald and David and Mark Freeman, Donald Taylor and David Weatherow for hosting this evening. We'll also have this recording up sometime in the next couple of days so that you'll be able to watch it again. If there's a lot of material in it, it'd be worth taking a second look at it. So y'all have a great evening, and we'll talk to you next week.